I'm Dr. Mila Brujic. I'm joined with Dr. Mike Cymbor for our second You Down with OCT episode on the OI Show. Dr. Cymbor, welcome back and thank you for joining us again. Again, for people that maybe didn't hear the previous episode, if you give them a little bit of background on yourself, that'd be awesome.
Sure, Mila. Thanks for the opportunity for being here. My name is Mike Cymbor, and I'm an optometrist at Nittany Eye Associates in State College, Pennsylvania. We're a large practice. We have 12 optometrists, one ophthalmologist, several branch offices, high volume, like many of you. But we deal a lot in the disease space, and as a result, we are very fond of our several OCT units.
So, Mike, today we're going to do a deep dive into that. And there's a few metrics around glaucoma that have really started to kind of increase their level of importance because I graduated 22 years ago. I know what you're thinking. There's no possible way this guy could be practicing for 22 years. It's true, Mike.
That's exactly what I was thinking.
But at that time, the only technology we had for any type of accurate measurements of the inside of the eye were the GDX. It was essentially a nerve fiber layer analyzer.
Sure, yeah.
We then got OCT, but we really were still hyper focused on the nerve fiber layer.
Yeah.
And it wasn't until spectral domain, Fourier domain OCTs, when we started to really look at that macular area and say, there's something here with ganglion cell complex.
Yeah.
If you could give us a brief, what is this ganglion cell complex that we hear about, and why is that important in glaucoma?
Yeah, so the ganglion cell complex, you said it beautifully, and we were really focused on nerve fiber layer. Nerve fiber layer was great, but we kind of thought that's where the story ended, and now we realize no, that's not where it ends. That's part of the puzzle. But maybe if we shift our gaze more to the ganglion cell layer, the nerve fiber layer, the inner plexiform layer, then we're going to we're going to see things there that sometimes we see prior to nerve fiber layer. Oftentimes it's complementary. But you remember, like, some of the companies that came out that were really paying attention to that. Some of our other companies said, no, that's voodoo, looking in that area in glaucoma. We realized, the research slowly trickled out at first, and then it all kind of hit at once, saying, if we look in the paramacular area, we are going to see change that, again, is oftentimes complementary to the nerve fiber layer, but using them together, we're going to become much better glaucoma clinicians. And that's really where the magic came when the light bulbs went off in our profession and say we have to look at both nerve fiber layer and the ganglion cell complex. And now today, I think anyone that's would suggest otherwise, we'd say no, that's you really need to look at those together.
Well, I remember back in the mid 2000s, there was a company that actually took a topography of the macular region in hopes of really, to a less of a sensitive degree, was measuring changes in that ganglion cell complex. And it is kind of interesting when you look at it, you really see that the density of the ganglion cell bodies and also the axons that will eventually create the nerve fiber layer are located there in a dense region. And it's so easily seen when you look at the natural flow of that macular region. But Mike, so here's a few questions that I have for you.
Sure.
First is there any situation where you're like, oh man, I really have to look at the GCC or put more weight on the GCC on this patient because of tilted discs, because of high myopes and all this kind of stuff?
Yeah, you actually answered the question, and that is when it comes to predominance of looking at the importance of looking at the ganglion cell complex, it really starts with high myopes. Any of our optometric colleagues, we see a ton of high myopes, and so really anyone above a -5 or a -6, we know the stretching that occurs. And as the eye elongates, that can play havoc with the optic nerve and nerve fiber layer. And so many of the databases, the normative databases, they won't even include patients above a -6. And if they do, they're kind of very sparse. And so it will throw that off. So if we look at, the color schemes of the nerve fiber layer thickness, when it comes to high myopia, it's just gonna throw it off. After a while of measuring the ganglion cell complex, we realized a couple of things. One, that stretching can still occur in the macular area, but it doesn't occur as much as around the optic nerve. So anatomically, it is going to be much better to measure the ganglion cell complex in these high myopes. And the other thing that gets very little press is it's all about fixation. And so as we're measuring nerve fiber layer, our fixation, the patient's fixation is kind of off to the side. And so if you don't have great technicians, and fortunately we have phenomenal ones, but if you don't have great technicians, that's going to further complicate the clinical picture. Whereas it's much easier for the patient to fixate, on the fixation, light alone. And that's what we're getting when we're looking at the ganglion cell complex. The patient is fixating straight ahead. So we have a tendency to get better scans.
You're so right, Mike. Every single time we do the glaucoma scans, our chances of getting a good GCC or ganglion cell complex is like close to 100%.
Yes.
The optic nerve, if there's going to be an error or something needs to be redone, it's always the nerve fiber layer or the optic nerve bed, which is, again, that same reason that you're talking about.
Yes.
Mike, so here's another question I have for you, because, there's normative databases, but there's also the importance of superior versus inferior, symmetry versus asymmetry. There's also, comparing the two eyes, and there's also the time frame. How do you, first and foremost, when you have a glaucoma patient, what's your go-to scans on the OCT? That's the first question. The second question is, how important do you feel asymmetry versus symmetry is, both superior and inferior, and also between eyes when you're assessing these GCCs?
Yeah, so when we see a nerve fiber layer defect, or at least maybe nerve fiber layer thinning, we should be able to just kind of follow the anatomy. We got the optic nerve, and we've got the supratemporal raphe and the infratemporal raphe, and so we should be able to follow that all the way across. So if there's a nerve fiber layer defect, at 11 o'clock, in the right eye, we should be able to follow that all the way across. So I love having, so my go-to scans really are the combination nerve fiber layer and ganglion cell complex. And on some of my instruments, there's two different areas, but on some, they'll actually image straight across. And so I can actually follow that nerve fiber layer defect all the way across. And so we know that glaucoma is an asymmetric disease, both right eye versus left eye, but also superior versus inferior. And so, there's good data that says your first sign is going to be an infratemporal defect. And so that's where I look first. And then the second most common is supratemporal. And so if I see those, then I know it's glaucoma, and I don't need really anything else. We know, visual field, it's going to take a while until we see a visual field defect. And it's always good to correlate structure and function. I'm not saying that that's not important, but when I see a defect in the superior inferior raphe that goes all the way across, I pretty much know that this is glaucoma.
So, Mike, with all of this that we kind of went over, one of the things that sometimes gets neglected in the discussion around glaucoma patients is the concept of gonioscopy and regularly performing gonioscopy on these patients, just to assure that, one, there's nothing that's surprising us in the angle. But the second thing is we can leverage our OCT technologies as well, too, to give us insights into this. I guess the first question is what scans and angles are you measuring, if you're utilizing that for angle measurements? And what patients do you feel like, this is the right person to perform this test on?
Yeah, that's great. Thank you for that question, because I'm really big on our colleagues doing angle assessment in whatever way they can, because there have been some really good studies out that say that our colleagues, both optometry and ophthalmology, are doing gonioscopy about 50% of the time. There was a recent study that came out and said, no, it's actually lower than that. This was a registry, a real world kind of study, and that percentage actually went down to about 30%. So I can't tell you how many times, as being a glaucoma referral center, that we're often getting referrals saying, oh, this is primary open angle, but yet when we do a careful angle assessment, no, it's actually a narrow angle or a closed angle mechanism, which is completely different. So in general, this is a call to arms to say, we need to be doing more angle assessment as a profession. The second thing to answer your question is, which scan am I doing? For the longest time, my OCT device would only take a very small part of the angle, so you really couldn't appreciate the full iris scan. But my one of my instruments, newer instruments, it now does angle to angle, and so you can see the whole angle in its entirety, and you can really appreciate iris configuration. So
Yep.
at a glance, I can tell whether or not this is an angle that I have to be concerned about. And I'm in no way am I saying that OCT replaces gonioscopy. It doesn't. You will always see things on gonioscopy that you can't see on OCT. But I will say, when you put those two assessments together, gonioscopy and OCT, it's really magic in terms of really understanding what you're dealing with from a glaucoma standpoint.
So, Mike, are there kind of general rules? Because I know now with the OCTs, you can put calipers in the angles. You can really get as
Sure.
sophisticated as you want to.
Yeah. Yeah.
Are there angle measurements where you say, this concerns me at this
Yes.
level, or
Yeah.
are there those cutoff points for you?
Yeah, so for me, a couple things I could say to that. One, I do think, doing the angles and the calipers, those are good things. And in general, we kind of say, if it's 20% or less, really kind of, scrutinize that angle and make sure you're doing gonioscopy at that stage. However, there are no companies, to my knowledge, that have completely automated the process. So it's not completely objective. You have a layer of subjectivity just by even doing the angles. And some of my technicians do a really good job of it, and some of them, could use a little work. And so for me, at least, I'm using angle to angle, and I'm just assessing how much space do I have, between the cornea and the iris right as we go into the angle. And then, of course, I'm doing gonioscopy, and I'm correlating those two things together. So a lot of times I'm just looking angle, looking at the iris configuration, and I can really get a good sense. I think you're pointing out a real weakness in OCT technology and angle assessment is we need a completely objective manner. In the same way, like I have a Scheimpflug imager that can give me, some really good metrics on anterior chamber angle volume, and I use those to my advantage. We're not quite there with OCT technology yet.
We're getting close though, Mike. I'll tell you, just the
So
shape
close.
of the iris,
So
and seeing
close.
people pre versus post-op cataract
Oh,
surgery. I mean, you
goodness.
get we see it at the slit lamp, but when you see that angle change and the way that iris configuration changes, you realize how much we're changing, like the space occupying thing, the lens, after cataract surgery. So it is kind of interesting. Mike, this was absolutely awesome. Truly, truly appreciate your time and sharing your wealth of knowledge with the group.
Mila, thanks for the opportunity. Thanks for this platform. Since you reached out to me, I went back and listened to so many of your podcasts, and just a fantastic job that you do in this space. So thank you for allowing me to be a small part of it.
Oh, Mike, appreciate you. And thank you all joining us for this episode of the OI Show, where we were down.